Thank you, Vincent. I'm really happy to be here, and I'm very excited to present on this topic, something that's very close to my heart. So, and that was a lovely introduction. So yes, I'm at the University of Miami. I am working along the side Vincent with the Spark project, but I also do a number of other things, and I am affiliated also with the Center for Autism and Related Disabilities, which is a autism center at the University of Miami. Oops. There we go. So what we're going to cover today, so we don't have, enough time to share everything about applied behavior analysis. So I'm going to try and hit on some of the things that I get most questions about. And so I'm going to spend a little bit of time talking about the background history of ABA. I think that's important really in understanding what ABA is. I'll talk about what ABA is, what even that therapy is. And then I'm going to show you some videos so you can see what it looks like in action. And then I'll also talk a little bit about what the structure of the implementation models are so that you have a better understanding. So hopefully that'll cover a lot of the pressing questions that people have before they start ABA, or when they're just getting started ABA, or even wondering if it's the right thing for themselves or their family or child. So the reason I wanted to talk about the background history a little bit is because ABA is a field of a therapeutic approach that really is very much tethered to a history of behavioral science. And so in the mid 1800s, early 1900s, behavioral scientists were starting to ask questions about ways that they could study behavior scientifically, the way scientists were studying biology or chemistry or other things. And, asking questions, things like, why do people behave the way they do, or what accounts for behavior change over time? And while these questions might not seem so monumental, the science itself really was kind of monumental, because when we think back to what how people were assessing or understanding behavior before science started looking at behavior. I mean, we weren't sure what kinds of things were controlling behavior. Was it Friday the 13th? Was it being born on a full moon? Lots of theories, lots of superstitions about understanding the way people behave. So the fact that scientists started to look at behavior from a scientific perspective was really helpful in guiding the development of treatments and therapies, although that came later, based on those scientific principles, right? And so, I don't want to go into too much detail about the history of the science, but just so you know, kind of the history of where it ties into applied behavior analysis. And I'm really just sharing this information because I think it's so important to understand that ABA wasn't just sort of developed by someone who was just thinking of what's the best thing that they think they should do treatment-wise. ABA really comes from is a therapeutic approach that's very much tied to our understanding of scientific principles that are about how behavior works. So, probably from your Psych 101 classes or history books, you remember Ivan Pavlov and his dog. And so he was looking at simple behaviors, the salivation of dogs, but he was able to understand how he could get a dog to salivate, not just when exposed to food powder, but also when exposed to a bell. And he could shape that and condition that behavior when it wasn't happening before. We had scientists like John Watson, who was, and this poor little baby's crying, but he was conditioning fear in babies, which sounds mean, but babies who were not afraid of bunnies or white rats before, he was able to pair those things with noxious sounds and suddenly condition fear. So he was starting to show scientifically how fear could develop when it wasn't there before. And then really a lot of behavioral science, a lot of behavior analysis and applied behavior analysis really comes from the work of B.F. Skinner. And so he was studying, he studied humans, but he also studied a lot of animals, rats, pigeons, and really understanding what are the conditions by which they learn new behavior and behave in certain ways. And the things that we really learned from him are the importance of consequences to our behavior, so that when behavior is followed by something positive, what we call reinforcing, that behavior is likely to occur more frequently. And we utilize that a lot in ABA therapy, that knowledge that we glean from B.F. Skinner and his understanding of behavior. Behavior that's not followed by favorable consequences tends to decrease or go away. And so we use that information as well. So just so you know and then these scientists and others, and it's also, I think, really important because we think so much of ABA as being tied to autism or treatments for autism. And the truth is, when Skinner and Pavlov and Watson and others were studying behavioral science, they weren't really thinking about autism. That wasn't their goal. Their goal is really just to understand behavior, why any organism behaves the way it does. And so the leap to treating autism really came later in the game. But all of this information they were investigating, finding answers about how behavior works, and I'll talk a little bit more about that as we move forward. It was helpful in guiding the development of what we now call ABA therapy. So ABA therapy, ABA stands for Applied Behavior Analysis. Behavior analysis really is that scientific part of that the scientists were uncovering. And the applied part really refers to the application of behavior analysis, the application of behavior science towards some kind of treatment. So when we take the principles of behavioral science and apply them systematically with the goal of improving socially significant behavior, that's really what we call ABA. And again, even this isn't directly, doesn't say autism in here either, right? So ABA can be used for other things as well. There's lots of therapies that are based on behavioral science that aren't specific to autism. But we know that a lot of therapies for autism are very much tied to behavioral science. So just so you know, some of the early applications of ABA, ABA's had a long, not terribly long, but it's had a long history. So when B.F. Skinner was doing his studies, he also was talking about how to improve education systems. He was training animals to work, help with government duties. He was guiding policy in government. Dr. Asrin started working with individuals with developmental disabilities, and he developed procedures for using behavioral analysis for toilet training, for tics, but for other things as well, for substance abuse, for helping people gain employment. But Ivar Lovaas is really the one who is most instrumental in tying applied behavior analysis to the autism community. And so and again, we have to really think about the history of autism, but when he first started working with individuals with autism, it was a time where no one had really talked about individuals with autism improving. A lot of times they were sort of just you would get diagnosed with autism and the message was, that's a shame, there's not a lot we can do about it. And so Ivar Lovaas was really instrumental in saying, maybe there is something we can do about it. Maybe there are some strategies that we can use where we could improve the lives of individuals with autism. And so his was really one of the first attempts at, and so when you hear discrete trial therapy, or sometimes people will even call it Lovaas therapy, he took young kids with autism and he exposed them to ABA type therapy for many hours per week. And again, this was the first attempt. So things have evolved since. The strategies and the procedures and all the application has probably evolved for the better since when he did it. But even then, when he was applying applied behavior analysis to young kids with autism intensively, the kids he was working with were making really important gains. And because of that, that was really instrumental in the field of autism if nothing else, for the idea that kids with autism really are capable of learning skills that we didn't know they were capable of before. Now it seems hard to imagine that that was the case because we know so many kids with autism are very capable of learning, but that wasn't the mindset back then. So when you hear the term Lovaas therapy or you hear discrete trial therapy, this is really comes from Ivar Lovaas, who was a professor, a scientist, who was taking behavioral science, knowledge about behavioral science, and applying it in a way to develop a therapy for kids with autism. So let's talk about what does that term mean. When I brought up the definition of applied behavior analysis, I said that it was for the purpose of improving socially significant behavior. And behavior is a broad term, right? It can mean so many things, but generally we're talking about behavior that is something that is observable, something that is measurable, and something that is going to improve someone's life or ability to participate meaningfully in their community, or participate more meaningfully in their family, or have a more endurable existence, less frustrating. And so the things that ABA tends to target, particularly in the autism population, are two things. One is on things that behaviors that we can increase or improve, remediating deficits. So we spend a lot of time focusing on improving communication, improving socialization skills, improving self-care skills, and also safe behavior practices, right? We want individuals to learn how to maintain their safety throughout their day, and so we work on those kinds of things. But we also work on reducing some of the behaviors that are going to essentially interfere with an individual's ability to meaningfully participate. So when sometimes we see cases for ABA therapy when an individual is engaging in aggressive behavior or self-injurious behavior, that's behavior when that some individuals will do where they actually are trying to or are hurting themselves, either biting themselves or hitting themselves, and then other things like destructive behavior or destroying property or materials or so forth. So just a range of things, but really what we're focused on are talking about the problems, describing them as a behavior. What's the individual doing that is a problem, right, for them or for their family or for their community? And what are the things that we would want them to do that they're not doing? We want them to be able to communicate more effectively. We want them to be able to socialize more effectively. And so those are the target goals for behavior therapy. And behavior therapy tends to be pretty specific about what it's targeting. So when you're working with a behavior therapist, they should, and they often will, be able to tell you very specifically, communication is kind of a broad term, but we're working on specifically how to request certain things or how to communicate when you're feeling pain or something like that. So even within these domains, you'll see that behavior analysis is pretty specific with the things that they're targeting. Okay. So I just want to show you some examples of ABA in action, and these videos come from different sources of our clinical services at UM. And I think this is helpful because one question I get a lot from families is when their families will come and say that they've been referred for ABA therapy, and they will say, I don't even know what that is, or what does it look like? What happens in ABA therapy? So hopefully some of these videos will just give you a little bit of insight into what that even looks like. So let me set this up for you. This is on the right is Bettina. She's one of our graduate students. And on the left is a little guy who is just barely 2 years old, and he is struggling to communicate effectively. He has very limited attempts to communicate. So in this little session, it's just a short clip, what you're going to see is that she's using some of the behavioral strategies of reinforcement, right? We talked about using positive consequences, favorable consequences to increase behavior. So she's going to use these bubbles. That's one of his favorable consequences, one of his preferred things, as a reward for his communications.
Bubbles, good job. Good job, King Bubbles. Woo, lots of bubbles.
And you notice right here that she pauses just a second to give him kind of increase his motivation to respond. So if he wants that bubble, she's giving him a chance here to, squeak it in. Oops.
Good job asking for more.
So he signed more. That's a term that response that he's already
Bubbles.
there. And he said bubbles.
Bubbles.
So that's an example of an ABA learning opportunity where we're using reinforcers, in this case bubbles, rewards, to increase his communication responding. And in this case, he's making a request for something that he enjoys. Here's another example. This is our early intervention clinic. We have a little clinic where we see 2-year-olds. So this is Anna as a graduate student. And this little girl is going to, Anna's going to ask her to imitate an action. And imitation is a skill that is often a focus of instruction in ABA therapy. And really that's because we know imitation is such an important kind of skill for learning how to learn. A lot of us, when we are in a situation, we're not quite sure what to do. If you walk into a new restaurant and you're not sure where the line is, you often look around and see where other people are going. So you imitate those behaviors. Or if you're, navigating somewhere else, or we use imitation all the time as a strategy, and it's a really effective strategy for the most part, and how to figure out how to problem solve situations when we're unsure. And so in ABA therapy, we take the time to actually teach kids to imitate sounds, imitate actions, imitate play, all of that for the purpose of that learning to imitate is kind of an important skill in and of itself. So you'll see this same idea of reinforcers. Anna's going to offer her a choice and then provide her the opportunity to imitate. Oops. Sorry. There we go.
Good job. Ready? Do this. Awesome job. Nice job.
So again, you see that Anna gave her the opportunity to pick what reinforcer she wanted at the beginning of the session, and then she gave her the opportunity to imitate. And then when she did imitate, Anna rewarded that behavior by giving her access to that toy that she chose. So we're using the Skinner operant conditioning. You reinforce the behavior you want to increase and provide positive, favorable consequences after it happens, in order to increase the likelihood that that behavior will happen again. Here's another example. So this sweet guy, Kevin, he was here. He came in with his mom. This is his mom here up here that he's giving a little kind of hug, and she's the one over the sink with him. He came in because although he very much enjoys brushing his teeth, his mom was struggling with the fact that he was enjoying some aspects of it so much that he wasn't getting through the toothbrushing routine. And so she found herself having to always be there with him and always have to keep reminding him what to do, and keep, for example, he would like to watch himself in the mirror, and he would just stand there for a while and giggle, which isn't so problematic if you go back to the routine, but for him, the going back to the routine wasn't happening. He would like to take his mom's face in his hands and just give her some lovies. He loved the water, would like to put his hands in the water. And so, not that any of these steps not any of these behaviors independently are so problematic, but the problem really was for mom to be able to have him brush his teeth and go through the entire sequence in a way where he could do it all by himself. And so the goal of working with him really was to build some independence and also to teach mom. So really kind of, we have two clients here. We have Kevin and his mom, teaching his mom how to teach him to be more independent. So the way we did that with Kevin is using a schedule, but a schedule of pictures that he could follow to keep track of his own behavior, keep track of his own sequence. You see, we started with the pictures on the wall. He was having trouble tracking those, so we just moved to pictures on a little ring here. But I just want to give you a sense of what that looked like. So what we've asked his mom to do is to give him little subtle reminders without using a lot of language, just gestures, but reminding him not what to do with the toothbrush and the toothpaste, but reminding him to look at the picture, because that's really what we want him to do. We want him to become independent at looking at the picture and following the schedule. That's the skill we're teaching him. So she's pointing there as a reminder to turn the page. And he's looking at a picture of someone brushing their teeth, and that's his cue to brush his teeth, and he followed that. Now he doesn't have to tap the picture, that's just something he does, but that's fine. Sorry, that's a little bit gross, but. So he starts to get distracted, and mom doing a pretty good job just bringing him back. So that's Kevin, and you can see it's in progress, right? He's not all the way there yet. He hasn't mastered this, but it's an improvement, and it's continuing to improve. And so again, you know, part of ABA is not necessarily the teaching just the skill, but also teaching kind of broader skills that will help you in the long run. So self-monitoring, keeping track of where you're supposed to be. Those are all things that we learn to do through calendars and different mechanisms. And so teaching Kevin to use some kind of system for monitoring his own behavior and understanding when he should be doing something and when what he should be doing next is certainly an important skill that he can use in other contexts as well. And also giving his mom a tool to work with him so that she doesn't feel like it's going to go on forever where she has to keep reminding him every step of the way. And she's clearly not frustrated with him. She enjoys him very much and all this. She just wants him to be more independent. Couple more videos I'll show you. So this is a little girl, a girl who's struggling with eating a variety of foods. She has a very limited diet. She's not undernourished, not malnourished, but her parents would prefer her to have a healthier array of foods that she will consume. So in this session, I'm going to show you a couple of videos. We're working on her eating chicken, which is not a preferred food for her. So I'm going to show you first what happens. This is when she's before the treatment. This is what happens when she was initially exposed to chicken. Get this play. Oops. Nope, sorry. There we go. Even the sight of chicken was horrible. So with the treating the picky eating, we see a number of cases like this where kids who have limited diet. So I just want to also point out that before we treat kids for eating food selectivity or picky eating, we always make sure we get medical clearance, because there are some situations where kids really do have difficulties swallowing or difficulties with gastrointestinal issues. And so we never want to expose kids to situations that are potentially a choking hazard or that they're going to make them uncomfortable. So this is a little girl where she's gotten medical clearance, and the doctor said, you know, she's fine to eat these things. She just doesn't want to eat a variety of foods. So the treatment that we've been using with her, again, it's so much of it is based on using reinforcers to increase behavior. But here we had a little girl where it was going to be really hard to reinforce eating chicken because she wasn't having it, right? She wasn't getting anywhere near that chicken. So we took a step back and we set up a sequence where she was earning reinforcement for even just touching the chicken. At first it was touching the chicken, then it was putting the chicken, holding it in her hand. And then here you'll see here, we got to a point where she was, not good at the play part. So this here, you'll see she's just putting the chicken to her nose. That's the stage we were on here. No.
Oh, you're so cute. Right, sit down. Thank you for sitting so nicely. Put that chicken to your nose and you get the M&M. Wow. Wow. Awesome. So fantastic. Oh, that's so cute.
Now it seems like a silly goal, right? Like it's not like we need a child to put chicken to their nose. But what we really do is just progressing through baby steps to get to where we're trying to get to, which is her eating chicken and other foods.
The next one is the last one.
And so when, you know, she was successful there, she wasn't crying anymore. And then they moved through additional steps. They got her to put the chicken to her lips, put the chicken to her tongue without requiring that she eat it, and eventually get to the point where.
Eat the chicken and we get the video. Good job. You're going to keep eating.
So here she is. She's eating the chicken. She's eating it slowly, but that's okay.
That's okay. Ah, good eating. Nice job, Emily. There you go. Wow. Yay, you did it. Now we can see that video.
So once again, you see the iPad and the M&Ms are her reinforcer, and they're using those rewards as contingencies to increase the likelihood that she'll engage in that behavior in the future. And so this was a process where we couldn't use reinforcement alone, not easily anyways, but but a process by which we took a skill and broke it down into little itty bitty components that we could get her to do in a way where she could earn the reinforcer and take those baby steps and build them up into a way where she's doing the things that are going to keep her healthier and able to be in a bigger variety of settings where she's not screaming at a restaurant when someone orders food that she doesn't like. And this is the last, Lenny's the last kid I'll show you a video of. I just want to warn you that a couple of things. So I'm going to show you, this is Lenny. He's got some self-injurious behavior that he was brought to the clinic for. He hits his face to his hand to his face and his hand to his chin, and he gets real upset. And so as you watch this, just warning you that it's a little sad to see that, but that's why he's here. The other thing I wanted to point out before I show you this video, the other issue that Lenny has is that he likes to keep his caregivers very, very close to him. And so in some of the videos, it almost looks like the therapist is holding him. But in fact, he's holding them. And that's just another thing that we have to work on, because you can't have someone tethered to you all the time. But I wanted to make that clear so that you didn't get the impression that the therapist is holding him down. So she's here trying to block his hands as he hits himself, but not to restrain him. Poor guy. And you can even see here that his hand is grabbing hers. He's holding on tight to her. So that's another problem that we would address, but not the biggest priority. The biggest priority right now is the self-injury. So part of what happens when a case comes in, or a child is exhibiting, or an adult even is exhibiting self-injurious behavior or problem behavior like that, one of the things that we do first is try to figure out what it is that's motivating that person to engage in that behavior. Are they trying to communicate something? Are they in pain, or is something going on that that we can better understand what that behavior is getting them? What is in it for them to do that? And so we assess that in a number of ways. But I'll just show you in one quick video. This is Dr. Leon in the blue shirt. She runs our severe behavior clinic. And so she's going to ask him, the sound is not great here, so I apologize. I wish the sound was better. But she's going to ask him to complete one little task, which is to point to, I think she says green or blue, to identify a color on this little piano she has in her hand. And what you can see is that this upsets him. Even the thought of being asked to do something causes him some distress. Here we go. So he hits his hand to his head there. And even when she moves it away, now he's upset. So that's important information for us as behavior analysts and how we go about treating it. Because to us, at least in this scenario, and this wasn't the only thing we found with Lenny, but at least in this scenario, what we found is that he was partly using that self-injurious behavior as a way to communicate to people like, back off, I don't want to do that, or I want that task to go away. And so rather than just trying to get rid of this self-injurious behavior, our goal is to also give him a appropriate way to communicate that information, because certainly there are times when you should be able to say, I don't want to do that, or I don't like this. And you shouldn't have to hit yourself in the head to to do that if there are easier and less painful ways to communicate. So this is one of the first sessions where Dr. Leon is working with Lenny to teach him to use an alternative response. And because he has no language, she's going to present a green card, and his job is to hand that green card over to someone, and that green card is really just a signal of I want this task to end. So what you'll see here when this happens, a therapist is going to walk in, she's going to present the task to him, and then before he can engage in any self-injurious behavior, Dr. Leon's going to assist him in handing over the green card to get that task to go away. So this is one of his first exposures. He hasn't learned to communicate effectively yet. This is part of how we're teaching him. She places the piano. She's working hard. She's got to show him the benefit of handing this card over. He gives the card that communicates to the therapist, no thank you, I don't want to do this. And then she leaves. So it's going to take some practice for him to learn that. But that's what they're going to use as what we call a replacement behavior. And so here you'll see that after a few sessions, Lenny is starting to get the hang of it. In fact, he even starts to what was funny is the people who were working with him, some of the family members and the clinicians he had before he got to our clinic, were surprised to find out that he actually knows some of his colors. So here she's going to ask him to identify some colors, and then he's going to spontaneously, when he's ready, hand her that green card. Oops, sorry, haven't mastered this part yet.
Good job, Maddie. Touch blue. Wow, see, you got it. Good job, Lenny. Touch red. Okay, you don't have to.
And so she's being very overt about it. She pushes it away really quickly. She moves him away from the toy, and she's really trying to let him know that when you communicate appropriately, then that's going to be powerful. And for him, that the reward is getting that task to go away. And so this, again, it's not the end of the therapy, right? Eventually we'll be able to work on getting him to complete more tasks before he can earn his break time and so forth. But right now we're really trying to just address this self-injury, where he's learning that he can communicate by handing over this card as a way to say, hey, I don't want to do this anymore. It's not, I need a break from this, you know, whatever you want, however that would translate into words. Instead of having to hit himself in the head or other ways to get people to understand or to back off with those tasks. Okay. So those are the videos I wanted to show you. Hopefully that gives you at least a little bit of idea of what behavioral therapy looks like. But now I just want to spend a few minutes talking about what the process of behavior therapy is in terms of if you start getting behavior therapy, what's going to happen. And just try to go over some of the things that I think a lot of people have questions about. So really when you go to see a behavior therapist, the process by which the therapy proceeds is usually there's a process of trying to identify what are the target behaviors that you want to address. What are those high priority behaviors that you want to start with? What are the things that are most problematic or most concerning that the individual isn't doing that you want them to improve on. So it's identifying those target behaviors. Then the therapist will work to develop a treatment plan. And that treatment plan is often very individualized. So it's not as though every kid who comes in with self-injury is going to get the same treatment plan. It's going to be a treatment plan that fits not just the type of behavior they're presenting with, but also the reasons, the environmental reasons for which that behavior is presenting itself. And so an individualized treatment plan will be developed. That plan will be implemented. And then there's also, we call ABA very data-driven treatment, because as kids or as adults are getting ABA therapy, the therapist is taking a lot of data on their progress, or hopefully not, lack of progress. But if for some reason the treatment plan isn't working, we would see that in the data as well. And so we're constantly reviewing the data to say, okay, this behavior is on an improving trend, or it looks like things aren't really improving. Maybe we need to modify the treatment plan. But we monitor progress through data collection. And then if there needs to be a revision in a plan, sometimes we need to revise what we're doing, or sometimes we need to move to another target behavior. Those are all things that happen through the course of ABA therapy. And that's pretty consistent across ABA therapists. We also talk about different ABA treatment models. So a comprehensive treatment model is I think what many people think of when they think of ABA and autism, that someone's getting a lot of therapy for a lot of hours. Usually this is early intervention when individuals are getting a comprehensive treatment plan, and that ABA plan, and that usually covers a lot of different domains of development, usually social play, communication, self-care skills, all of that in a intensively provided therapeutic program. But there are also individuals who get a very focused treatment where they aren't necessarily getting 20 or 30 or 40 hours a week. They might just get, an hour a week or 2 hours a week. And those are the cases where perhaps you're working on something more limited in terms of the number of target behaviors. Maybe you're just working on picky eating, or maybe you're just working on some kind of aggressive behavior. And that's the type of ABA therapy that we typically see applied for individuals who are past those early years, who are older, and into adulthood. Another question that comes up a lot is, for me at least, parents will often ask me about this tiered therapist model. So it's a very common model in behavior analysis where there's a supervisor, a behavior analyst who is in charge of developing the treatment plan and monitoring the treatment plan, probably the professional that you interact with most initially. But then that's not necessarily the person who delivers the treatment. As particularly for kids who are getting really intensive treatments like 20, 30, 40 hours a week of therapy, the person who's actually implementing and delivering the therapy is usually someone who is a technician who is working underneath a supervisor. And so I think that can sometimes be confusing because, when you go to see a professional, you assume that professional is going to be working with you and your family, and that supervisor or behavior analyst should certainly be in charge of the primary decision-making, clinical goals, and all of that. But it's very common for a technician to be the one who's working one-on-one, doing most of the direct service delivery, collecting data. So in terms of finding a therapist, I just want to point out that, if you have a good resource, good referrals are always helpful. If you have a physician or someone who can point in the right direction of a good therapist in your community, that's great. That's probably one of the best ways to find a therapist. But I also think that I just want to share that the Behavior Analysis Certification Board is the most widely recognized certification board for behavior analysts. And so if you don't have anyone who can recommend a therapist. One way that you can at least find someone who has the credentials is to go on to the website www.bacb.com. That's the certification board, and right on the home page it will point you to find a certificate. Those are people who are certified. So only, I mean, not the only, but one of the benefits of using a certified behavior analyst, and you know, the requirements for different insurance companies and different state licensures, they vary from state to state. So, I mean, this is kind of a general recommendation. But the Behavior Analysis Certification Board certifies people who have certain educational and experiential meet these requirements. They have to pass a board examination. They have to meet continuing education criteria. And they also have to abide by an ethical and professional standards. And there are disciplinary actions for certificants who don't follow those guidelines. And so using this as a resource to find individuals who can provide behavior therapy is, at least when you have someone who's certified by the board, you know that they've met those requirements. And just so you know what we call this, so the Behavior Analysis Certification Board, the BACB, the term that they use for people at the supervisor level is either BCBA, Board Certified Behavior Analyst, or BCABA, Board Certified Assistant Behavior Analyst. Those are individuals with a bachelor's degree versus the BCBA has a master's degree. But those are both levels where they have the training to do the supervisory level procedures. And then the BACB also certifies the technician, what they call them registered behavior technicians, or RBTs. And just in case you ever come across those terms, that's where they come from. And last, I just want to point out, there's been lots and lots of studies showing the effectiveness of ABA therapy for treating autism. But I just want to point out there's the two resources that have good synthesis of the data. One is the National Autism Center that reviews evidence-based practices for treating autism. And they review not just behavior analytic treatments, but they review tons of other treatments. And they have categories of what they call established interventions. These are the category that they place therapies in if there's enough empirical evidence demonstrating their effectiveness. And so the largest category for them of the established interventions is the behavioral intervention category. And then the National Professional Development Center on Autism Spectrum Disorders, they do their review of autism intervention is they do a slightly different process for reviewing literature, but they qualify things as being evidence-based practices. And they describe that their category of evidence-based practices consists of interventions that are primarily applied behavior analysis techniques. So they don't look just at ABA as a whole, but they look at the individual techniques within the ABA practice, like use of reinforcement, use of other strategies. And last thing, this is my last slide, and then I can take questions, but I just wanted to end with a quote that I love from Skinner, where he says, "I'm not trying to change people. All I want to do is change the world in which they live." And I think as a behavior analyst, I mirror that thought. My goal in working with graduate students and working with families is really to help them arrange the environment and arrange the rewards and the contingencies so that people can enjoy and live a more meaningful and productive life. That's all I have. Do you have questions?
Thank you so much, Melissa. Yeah, we did get a few questions in. We will only be able to answer a few, so I'll try to combine them if I can. There were some folks asking about ABA for individuals with Asperger's or people that need less support. Could you talk a little bit about that?
Sure. Yeah. So, ABA really is a therapy that if we can identify a target behavior, a behavior that warrants intervention, then we can apply the principles of behavior to address it. And so individuals with higher functioning autism, Asperger's disorder, oftentimes we can find define behavioral targets that are amenable to change, whether it's a lot of times it's aspects of conversation that we might address. So how to enter a conversation appropriately, how to terminate a conversation appropriately, and so we can set up ways where we can provide some instruction and provide some practice and provide reinforcement for doing that. A lot of other things involve some of these higher levels, some of the same skills actually, but at a higher level. So some of the organizational aspects of life can be really challenging for individuals with higher functioning autism, maintaining a calendar or schedule or putting things on the calendar or keeping track of your homework assignments. And so the same way that Kevin had that little flip chart of visual schedules, we could certainly adapt that in a way that's more appropriate for someone who reads or who is able to use a more high-tech system. But the same idea in place where we are providing some information about how to go about engaging that behavior and then some reinforcement to do so. And those reinforcers, are really very individual specific. People like different things, and so we want to make sure that the reinforcer is valuable to that person that we're working with. Did that answer the question?
Yes. Can you talk a little bit about how clinicians kind of draw the line between using ABA for improving behaviors that are essential for functioning, or improving behaviors that might be harmful, to sort of just trying, I guess this is getting at what you just said at the end, right? Where do you draw the line between where it feels like you're changing someone versus where you're actually working with someone on trying to help them to improve their life?
Yeah, and I think that's a really good question, and it's something that we spend a lot of time talking about with our graduate students. And we kind of playfully call it the so what test. If it doesn't pass the so what test, then it's maybe not something we should be intervening with. So like the little boy who was doing, in the beginning, where she was blowing the bubbles and he was communicating, and if you notice, but he was doing some hand flapping and other things that certainly we know are autism type behaviors. And, if you were an older child that behavior was interfering with his functioning and socializing with kids at school, maybe that's something to intervene with. But at that point in time, for us at least, that's not a behavior that seems to be interfering with anything. It's not a behavior that's causing anybody harm. And so, she's not making any attempts to stop him there from hand flapping. She's working on the behaviors that seem to be a priority. But, I think it is something that we have to be careful about, remind ourselves about. Like if we can't come up with a reason that behavior is worth addressing clinically, other than it just annoys somebody or somebody doesn't like it, that's not necessarily a good reason, right? And some behaviors are worth addressing in some individuals and some are not. And so we just have to be really, really conscientious about that. And going back to the kind of the idea of what, if we address this behavior, what does that mean for that person? Is that going to lead to them being able to live more meaningfully within their community, or participate in things that they weren't able to participate before that they want to? Versus, is it just something that someone doesn't like, and in which case we would advise that maybe that's not really worth a therapeutic intervention, right? But it's something that's an ongoing thing that we have to continually remind ourselves about as therapists.
Yeah, definitely. Okay, that was really helpful. Thank you. Can you talked a little bit about this, but can you give a little more detail about the kind of education that's involved in training certified ABA therapists, specific to autism?
Yeah, so the Behavior Analysis Certification Board is really the most widely recognized standard for training criteria to be certified. And so they have different levels of certification, but at the BCBA, the higher level, someone has to have a master's degree with a certain number of hours of training in behavior analysis, the equivalent of a master's degree. So I would say like 36 credit hours, kind of something like that. They do it by clock hours. And then you have to have a certain amount of supervised experience. So our students get that through a practical courses, and it varies depending on the type of supervision, but up to around 1,500 clock hours of supervised practice. And then once you meet those requirements, then you can sit for the board exam and get your certification. The criteria is a little bit less at the BCBA level, but still you have to have a bachelor's degree and 1,000 clock hours of supervised experience. And then the registered behavior technician is much less. It's kind of a technical training. I think it's a 40-hour course, but that requires a lot of ongoing supervision, continuous supervision. So yeah, it's intensive, and I think that that's important. And even in, I know that even students who graduate, we continue to collaborate together. I don't know if you're ever really done learning, and that's why there's always continuing education requirements and conferences and things that we all attend to try to make sure we stay up to date on what's going on.
Okay, excellent. All right, well, we are at 1 o'clock, so I do want to be respectful of everyone's time. Thank you so much again